So technical difficulties are a bit hard. Recording. Okay. I think we're ready. So happy Critical Care Week. Thank you everybody for the work you do. Obviously we survived the semi-zombie apocalypse, but the zombies are still coming. In case you're wondering, it's not really the virus that causes it, it's the vaccine. If you ever watch any of those movies. So we still have a little ways to go. Today we're going to talk about liberation. I know you guys have heard me talk about this. We've been discussing it probably over the past few months, actually probably the past 2 years that I've been here. We have a desire, or I have a desire to make a more formal push for this to develop and implement within the coming year. You may see a year sounds like a long time, but as I've looked over I'm going on my 2-year anniversary of being here. There's a series of obstacles that we have that we're facing in practical terms. I think COVID really helped make those apparent. The ability to get in and out of a room, obviously it's isolated and PAPR, and then obviously your staffing situations being what they are. So I've tasked a few people with trying to give me some listings of obstacles and things that, areas where we can high impact and high yield. And we'll talk about that a little bit today. This is an ongoing conversation, though, that today is not going to be the last conversation about it. This is more or less just to get you abreast of the idea and be prepared, because this is going to happen. And so my general encouragement is to get on board, because it's going to happen one way or another. Some of the data I'll present today, one reason why I think it'll happen is because when a society like Society of Critical Care Medicine puts its name on it, puts its name behind it, it's not long before the federal government will look at it at some point as well. And for better or for worse, we'll be tasked with having to implement this in some fashion. Better that we start laying the groundwork, laying the foundation, laying the practice, getting our culture changed around this as well, so that when the feds do come and knocking, we're already ready to go. The fun part about this, though, is we're already doing it to some extent. What I can say is we cover aspects of it. I think the most important, though, as we go through the conversation, though, is the ability to do it consistently and do it day to day, do it shift to shift, and hit every piece of the bundle. And so historically, if you guys have followed this at all, and you look through your all's literature, and when I say that, I mean RT as well, the bundle's been in place for probably 15 years in some fashion. And it started off as the ABC bundle. Historically, it was all centered around mechanical ventilation. It was all centered about getting people off a ventilator. And it has morphed into something a little bit greater, which one of the reasons why it's called liberation from iatrogenic injury, was the recognition that what we do, no matter how good we are at saving the person's life, we're leaving them debilitated, whether we realize that or not. It used to be, when I was a fellow, once they left the unit, pat on the back, see you later, don't let the door hit you in the backside. Hope to not see you again. If I do, it's someone else's mistake, not mine. God bless and have a nice day. As medicine has advanced, as we've recognized the side effects of what we do, the obvious realization is what we start in the ICU carries with that person from then forward. There are several studies out there, and I didn't bore you with it in this lecture, that we'll talk about. It takes upwards of a year for a patient to recover in some respects. And even at that year, anywhere from 40 to 60% of them have some sort of neurocognitive difficulties. So when you start talking about, say, a demented patient in the ER or in the nursing home, I hate to say, not really that big of a deal. It's not going to have that major impact. But you take one of you, put you through the same critical illness, you're not going back to work, much less functioning on your own. What does that do? I mean, what depression does that bring on? What PTSD does that bring on? I took care of a lady when I was in Kirksville that was a massage therapist, got her off the vent 5 days. She had ARDS from Bactrim, got her in and out. I mean, honestly, very timely. She had to close her practice because she couldn't functionally maintain it. The effects of critical illness are far-reaching, impactful, and definitely something that we can impact ourselves. The downside being that post-ICU syndrome, which again we'll talk about, really there's no way to fix it other than prevent it and minimize it. Current therapy protocols that are out there, post-ICU management stuff that's out there, none of it improves outcomes. Most of it is going to be what we do and how well we do what we do at bedside in the ICU during their stay. Right? If you have questions, please speak up. Let's see if it goes. No, it doesn't. There we go. There we go. Holy crap. Okay, I will speak slower. So this infographic, which I think is very, very important to understand, if you don't get anything else out of this lecture, I really don't care other than this. The realization that by implementing the bundle and implementing this practice with consistency, you see a decrease in next day mechanical ventilation. I mean, if they're brought to the ICU or they're extubated in the ICU, the chance of them being mechanically ventilated again is decreased by 72%. Huge. Reduction in hospital death within 7 days, 68%. Decrease in next day comas, 65%. Reduction in next day use of physical restraints, 63%. 46% decrease in ICU readmissions, 40% decrease in next day delirium, 36% decrease in likelihood of being discharged to nursing home and rehab facilities. So just doing what we're supposed to do with consistency and with obviously some nuance changes all these things. This was based off a 15,000 person study that was followed. So this is not something small. The other thing that the study will show is implementation of each individual piece of the bundle had synergistic effects as you added those. So if you were able to accomplish all pieces of it, you saw a far greater outcome than just 1 or 2 or 3 or 4 kind of thing. Okay, so it is imperative as we get our minds wrapped around this process and this concept, as we look for process improvement, implementation, and modification, it's everything. There's no real just doing one. It's doing all of it. And there's no reason why we can't. As we look through these different topics, it's really nothing that we're not doing. It really isn't. We're already doing it, but are we doing it as well as we can? Are we communicating as well as we can? Are we adjusting as quickly as we can? That's really what it comes down to. Change view.
I think we're good.
So this infographic is really just showing each piece. So A is for assess, prevent, and manage pain. When you look at the PAD guidelines, you know, why were they called the PAD guidelines? So I've been doing this since I was a resident, and you know, I'm not as old as some people in the room, but I'm older than others. Hi, Betty. And I remember writing a sedation and analgesic order set for Kirksville when I was a resident back in 2000, 2001. So the process of these implementations, it's not new. It's nothing that hasn't been done. But they finally gave it an acronym called the PAD guidelines because people were too confused, I guess, what we're supposed to do, with P standing for pain. Surprise, A for agitation, and D for delirium. That was the first attempt to sort of standardize and encourage and regiment how we look at these patients. For those that have worked with me for obviously the past 2 years, you know, I think we know that using an analgesic-based approach to mechanical ventilation has allowed us to cut back on our sedation, has allowed us to wake our people up a little bit quicker. I know when Shannon and I were looking back, we were able to cut down on ventilator days pre-COVID. So the ability of having these people so snockered, I remember hearing various individuals talk about how sedate we thought our people were, and as we adjusted to an analgesic-based approach, we were able to minimize that or at least cut that back to some extent. That doesn't mean we still don't heavily sedate people at times. It doesn't mean that we don't have room for improvement, but I would hope that those of you guys in the room that have seen this practice, you've noticed that there has been a change and there's been an improvement. Why would pain control be paramount in this population? What's today? Thursday, it's Raven. We're always Monday, Wednesday, Friday, Sunday. Why would pain control be paramount? Period. Well, so for those on the computer, what was said was because the tube's in your airway. I mean, you take everything else out of the picture. An intubated patient has a tube in their airway, and you're not supposed to have a piece of plastic between your vocal cords. There's a reason why you cough. There's a reason why it's such a stimulant to be trying to intubate someone. It's a reason why anesthesia uses some patholytic medications prior to intubation. There's a reason for that. You're not supposed to have anything in this area. So take everything else out of the picture. They have no other problem. They have a piece of plastic in their airway, and it's going to be uncomfortable. Okay. It doesn't mean they always need an infusion. Well, I know that's what our practice is, but they do need pain control. And take away the word pain. It's noxious. The term noxious stimuli. It can be anything. It can be them coughing. It can be the plastic. It can be anything. But whether they register it as pain is honestly irrelevant. The fact that you have a noxious stimuli, there's only one way to treat that, and that's with pain medications, usually of a narcotic base. Now, obviously, there's side effects in narcotics. There's issues we got to run into, and without question. But when you look at the balance between the pain the patient is feeling against the medication they're using, those will tend to offset one another. And I know I've seen any number of patients since I've been here. We're on 50 mics of fentanyl. That's it. They are interactive. They're able to work with therapy. They're still mechanically ventilated. You don't need anything else. Yes, I know there are those patients that you need to put them down and put them to sleep. However, the fact that you can still achieve some control of that patient with just pain control is enough. Okay? So what does that mean? That means highest priority is pain first. Always pain first. And as we get into each one of these categories, we'll talk a little bit more about it. But so A is, again, the assessment, prevention, and management of pain. Assessment, that means putting your numbers in. What was their CPOP before you dosed them? Are you looking at their pain assessment? Do we do a good job of documenting what their pain was in a routine fashion? You got to be honest, we suck at it, right? So shift to shift, hour to hour, moment to moment, do we do a good job? No, we don't. So obviously that's something we can improve upon. Why? Why do we need to improve upon it? Because everything we choose to do is targeted towards that assessment. That assessment guides everything, should guide everything, should show when something doesn't work, should show when something does work. The whole goal is to minimize total amount of intervention on that patient to get them through that situation, okay? Questions about that?
The only thing that I see that when a patient is what we assume, I mean, if a patient is restless and anxious and whatever, is that because they're in pain or is it because they're, agitated for whatever reason? So the first thing we want to do is increase their fentanyl or increase their propofol when it maybe they need something else, like Ativan or something else to kind of. I mean, how do we know that their restlessness and their agitation is always pain?
Because you always assume that it is. You start there first. But when we've assessed it and you determine that it's not, then you move on. The mistake is when I've walked in the room and I've seen people on 25 of fentanyl and they're on 50 of propofol.
We should be going for pain medicine and using PRNs rather than.
You should assess the patient, determine what their need is, and meet their need with pain being a priority. After that is when sedation comes in. Pain should always be, we're still not changing. There we go.
There we go.
Good. So, I'll move on to this. Oh, I love technology. So it's not, I don't know how to describe it. I'm obviously not at bedside. Okay? I'm not going to be there in that bedside assessment. What I'm going to be is I'm going to tell you that these patients are oversedated, undertreated for pain, and that's going to compromise them. How to best move through that is in regimented fashion. This is really no different. One of the things I like about liberation is it's really no different than running a code. Obviously, they're not arresting, but it is the regimented approach to a common scenario with consistency. That doesn't mean there aren't going to be outliers. That doesn't mean there aren't going to be those moments where we got to do this, that, or whatever. But if we are consistent from person to person, moment to moment, shift to shift, hour to hour, then the vast majority of the patients will be treated with consistency, and pain will still be priority. If we're not calculating our CPOT, if we're not following what that does and doesn't do, how do we know what we didn't work? Well, they don't look like it did. You can't prove it to me. This is just your opinion. What's their assessment? If you are doing a consistent assessment that objectifies an approach the best we can for all of us, so that when I look at if I'm looking at the case and I'm not even at bedside and I'm just simply following and I see, hey, you know what, their fentanyl just doesn't work. Maybe it's not that pain control is the problem, it's the drug we're using that's the problem. So you may have to go up and sedate them, but it's because fentanyl just doesn't work for that person and we need to shift over to hydromorphone. Maybe morphine is the option that we have to use for them. In every case, in every study, it's never really the medication that's priority. We choose certain medications for a reason, but the reality is a targeted approach to the patient will minimize every amount of medication. I've had patients with PCAs pushing buttons on the vent. Why? Because this is uncomfortable. They have some control. If they can dose it, that's all they need. Pain is always, always, always the top priority. Here's the other part to that. Let's say they are under control, at least initially, and then they aren't. What does that mean? I don't know. Maybe it means they're constipated. Maybe that means their bed sheet is folded up underneath them and they're uncomfortable. Maybe it means they've got an elbow fracture that we didn't diagnose. Maybe it means that they're having chest pain and we don't realize it because they're too sedate to interact with us. If the patient's pain is controlled and they're not sedated, what can they then do? They can tell us what the problem is. CPOT scores are for the unalert. VAS is for the alert. Is anyone using the visual analog scale? Are you having a patient categorize your pain on a 1 to 10 scale and point to you where their pain is or isn't? When a patient's laying in bed for their entire stay, you cannot tell me they're not uncomfortable when they're laying in the same position, right? There is a lot of reason for them to be uncomfortable besides the ET2. Central line in their neck, the thing up their nose, their catheter, the fact that they want to poop, but they don't want to poop because they're uncomfortable and they're aware enough to not want to do it in bed, but now they're having belly pain and cramps. There's a litany of other issues that could be a reason for their discomfort. Cross medicine for time I've been a physician, pain is always an issue in the hospital. Always, 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 because it's a subjective finding. I would say the easy thing for us is what we're doing to them, we know is painful. Whether I'm suctioning them, whether I've got a tube in their throat, whether I'm rolling them, whatever it is, a lot of things that we're actually doing to them is painful. We know this. Had a couple cases, I think she was in bed 3, used to desaturate every time they went to roll her, every single time. Once they started dosing with fentanyl before they rolled her, that all went away. Why did she desaturate? Because she started coughing against the vent. Treating the discomfort was a way of dealing with these other issues that were occurring with the patient. So while you're correct that there's going to be those moments, have you assessed definitively what their pain is, definitively shown that their pain has been dealt with, and then there's still issues? Okay, you're right. Then we move on towards sedation. Sometimes you got to do it all at one time, but sometimes it's a matter of we did not deal with the pain first, and we're not dealing with the underlying issue the patient's otherwise facing.
So if they're on a fentanyl drip, we should probably always have a PRN fentanyl to use as an immediate, like if they're complaining of more and more pain,
Yeah.
go up on the drip from 25 to 50 or 55
Yes.
to 75.
Yes.
Always try a PRN, and then if that doesn't work, then
Yes.
we should.
So when I first started here, one of the things I tried to implement, and I put in my orders, and I got told initially that it wasn't, it didn't come across. Come to find out that was a bunch of BS. But the reality, I would put 2 boluses before increasing drip, right? So original process, originally was we have a fentanyl drip. There was a lot of reasons to go up. There was no reason to go down. The pressure they should be on nothing. The reality is they should have nothing going into their system. And they should have a PRN pain medication. That's all they need. I've had patients like that. I've had patients like that here, where they're on the vent. They're sitting there freaking texting. They're doing okay. Yeah, they're uncomfortable, occasionally cough, need a drug of some kind, and they're otherwise okay. We know we've seen those cases. Those are not impossible cases to have. Now, in our minds, we always think about the worst of the worst, which again, I get it. We got to protect the patient. But if our mental philosophy is to push down, push off, turn off, that's a different approach. That's why what liberation, I think, offers is, again, a shift in our perspective. It's not a matter of keeping them sedate and on the ventilator. It's a matter about doing the most with the least. How much medication do I really need? How much do they really have to have? Right? Why is that important? Because if you can get down to the least, you see improvements in their outcomes, improvements in the throughput to the ICU, improvements in extubation, improvements in post-ICU syndrome, improvements. This isn't a matter about what's convenient for us. This is a matter about what's in the best interest of the patient. And I can, if you want, I can send you 50 to 60 other articles on analgesic approach to intubated patients and the betterments of outcomes. Study out of France, I think it was, they didn't use any sedation in their patients at all. All they used was pain control. And that's all the patients needed. They're out of the ICU faster, so on and so forth. This is not a novel thing. This has been around for a long time. Go into your guys' own journal. I guarantee you, you will find article after article after article. Go into the respiratory care, you will find article after article after article. This is not something I'm just sort of making up, coming up with. Hey, I just found this. This has been ongoing. It's one of the reasons why Society of Critical Care Medicine is behind it. So this isn't about doing what we do differently. It's about thinking about what we do differently. And when you start looking at a patient with that perspective, you will start asking yourself, why do they need the sedation? Why are they not have, maybe the pain medication is not working? Why are we not up and walking? Why are we so asleep? Why are they not awake? Why are they interactive? Not, either sleepy and I had to do this, that, or whatever. It will become a priority in your mind as you walk in the room each and every time. Now, the challenge is the PRNs, right? Why is that a challenge? Well, number one is implementation of it. The order set in our system is not necessarily conducive to reminding you. The other is, in lieu of COVID, is how do you deal with that patient when you're the only one in the room? You're peppered up, they're in floored, whatever. You're sitting on them to try to keep them from pulling stuff out. Everyone else is tied up.
We had at one point talked about adding a bolus on the fentanyl. Is that something they can't do or
No,
can do? Or
working on it.
That's what I thought.
That was
would be
one.
helpful.
Yep, that was one of the big things. Well, that's where PRNs. I mean, I think the recognition that
So
why do you need a PRN?
would we then chart that someone? I guess that'll be a different discussion.
Yes, but the concept is, why do you need a PRN? Because incidental things occur, and if you don't have the ability to give them a PRN, then what are you going to have to do? Turn the drug up and sit there while it works, right? You take them from 50, you're not going to go to 50 to 75. You're going to go 50 to 100 because that's the only way to get them to slow down. And then you got to sit there, and then you're like, freaking A, if I'm going to turn that down, I got someone in the next room I got to go to. I'm going to leave it there. Oh yeah, let's keep that propofol at 50, and then I'll come back a little bit later, and as long as I feel like it. Yep. Now 12 hours later, we're still on 150. Now it's night shift, and night shift's like, freaking A, I'm not turning it down. It's like you had a shitty day. I'm going to leave. I'm going to let him sleep. Right?
Because my time when they need to sleep.
Right.
Now, my question too, I think it's the lost thing that everybody's forgetting, and I don't know that it's in the bundle anywhere even, is anxiety. Like, I think
It's in there.
that anxiety makes your pain worse and makes everything worse.
Sure.
You can't tell me that if I woke up in ICU with a tube in my throat, that I wouldn't be freaking out.
Sure.
And, I mean, even when we know better, we would be twice as freaking out.
Oh, of
probably,
course.
actually, versus not even thinking about it.
But how do you know that they're anxious? Ask them. Well,
Yeah,
no,
if they can
you-
tell them,
yeah, but you ask them. And if they can indicate to you and you say, are you having any pain? And they give you a no, and you say, are you feeling anxious? And they give you a yes, then you treat the underlying problem. What we're doing is we're treating our comfort. We're not treating theirs. We're treating what we believe to be an unsafe scenario, not treating their underlying problem. Medicine's pretty easy. Once you have a diagnosis, the treatment's always straightforward. The diagnosis is the problem. That's the challenge. That's the dilemma. Well, but if they're intubated and they're always in the vent, you start with priority. What is pain? If their pain's under control and they still indicate anxiety, well, I love the fact that they're awake enough to hear you, to tell you, to indicate to you that they're anxious. Okay, that makes sense. Let me get you a little bit of Ativan. We'll treat that underlying problem. Or we'll use a little bit of Prestex at that point. Or we'll, hey, are you sure you're not having pain? They give you whatever, you give them a little dose. Let's see if that works first. And if you still have some anxiety, well, here, we'll talk. Or guess what? I'll turn the lights on. I'm going to talk you through it. We're going to talk for a little bit first. And if you still feeling as anxious, I'll check on you more frequently, or we'll have other people on the unit coming in more frequently, and we can avoid medications or work the patient through it. There may be another way. That doesn't mean we don't have those busy days. It doesn't mean we don't have those moments where we have to, but the philosophy is to use the least amount of medications, not put them down. So if our philosophy is still to use the least amount of medications, then we'll do our utmost to use the least amount. And if those scenarios occur, I don't have a problem with that. As I told some night shift people, I don't want the philosophy to be, I'm just going to put them to sleep. I want it to be, you know what, we're going to come up with a routine. We're going to come up with a schedule, because there is a practicality against management that has to be balanced. And if they know with consistency, 10 p.m. to 4 a.m., you know what, we're gonna run them a little bit higher. We're gonna put their RAF score to a -2. We're gonna actively make them be more asleep during that time to try to minimize any of these acute ups and downs. But come 4 a.m., we're gonna do this, this, and this. I'm on board with that. We choose actively to make that our process. That's one thing. But when an individual person chooses to do it themselves, that's laziness. That's not consistency. That's not standard. That's when that one patient has more medication and everyone else is otherwise doing fine. That's where we have to work as a unit to be more consistent, because that's what gets these patients out of the unit faster, gets them off the vent faster, all those things, right? Again, practicality versus. So one of the big things I know we came up with was bolus up the pumps. Either this week or next, I've already talked to pharmacy, hopefully that will be fixed. So the combination of both an order set for, say, propofol, fentanyl, hydromorphone, where we can bolus at bedside. Ideally, you can see now, you go into that room, that patient starts losing their gourd. You can give them 50 of fentanyl, give them 2 cc's of propofol, stop that problem from occurring, never have to go up on the drip. All because they got to get cleaned up, they poop themselves, they're stressed out, whatever, they start coughing, you know, RT's doing whatever the weird crap they do. And notice I'm pointing at Laura primarily. Fire Miser does her own weird stuff too. But those things, you stop it right then and there, it's done. And then you may never have to go up on the drip. Wait a second, they're still having problems, you do it again. Maybe may not have to go up on the drip. No, I got to do it a third time, go up on the drip. How's a justification for going up on infusion? Ideally, they're on no infusions. There's no reason they have to be on infusions. Nothing says they have to be. That's out of convenience for us. Convenience for you. If there's a way to narrow that down, get off that infusion. There's no reason that says they have to be on propofol. Propofol is not therapeutic. It doesn't lead to better outcomes. It doesn't make their disease get treated faster. Fentanyl doesn't either.
There compared some studies where it used to be that someone from anonymous as a whole.
No.
Bring them up,
Everything's bolus. If anything, infusions are really recommended against. Or at least, the very least, you got to justify why they run an infusion. Yes, I got a person, I had to hit them. You know, they're a freaking trauma patient. It took me, 100 mics of fentanyl just to stop them. And they've got multi-bone fractures. Yeah, duh, they're going to need an infusion because there's no way that pain's going to get any better anytime soon. That makes sense. Here's the other caveat. Propofol, Versed are not analgesics by any stretch of the means. Well, they're sedate. Their body still senses the pain. Still does. Why are you on 50 mics of propofol? Because that's what it takes to keep them from moving because they're in so much pain. You put them on 50 of fentanyl, I know you guys have seen it, your sedation comes down. You don't need it anymore because you dealt with the real problem at hand. That, it's an alcohol withdrawal, different conversation. Propofol is therapeutic at that point. It's treating an underlying problem. But the average run-of-the-mill vented patient, that's not the case.
A lot better than we used to be, I think, of all of the pain mechanism treating agents from Tylenol to muscle relaxers to, coordinating all those things together on a routine basis.
100%.
And you don't have to give them a punch fentanyl and everything else, there's a lot of other.
Oh my God.
It's simple, but it makes a difference.
Right, but it's consistency is still the issue. So back to what Penny was asking earlier. Fine, let's say you try a dose of pain medication, doesn't work. Maybe the medication doesn't work. Maybe you need ice for inflammation. Maybe ketamine would be a better option. Maybe there's other options and things that we need to do. The 2018 guidelines actually advocated for scheduled doses of Tylenol. When I first got here, that's what I was doing initially. But the order set being what it was, it became arduous to just have to put that in every freaking time. Also, in talking to pharmacy, even though we've used scheduled Tylenol, we haven't seen a decrease in total amount of narcotics. Why? Because when the patient looks comfortable, we don't like to make them uncomfortable. We don't like to decrease to the least effective dose. Right? Maybe they're on 100, but really maybe they only need 50. So when I have my bolus routine in place, I would come in on a morning. I would look back at the total infusion, There were no boluses given the entire night, and they're still on the same amount of pain medication. No one even attempted to turn it down. Right? No, I get it. I get it, but it's back to the lack of philosophy. The philosophy is any of these medications, any of them, lead to worse outcomes. Period. If you were to sum up how much medication a patient would receive, and you could cut that by 25% for their ICU stay, their outcomes will be significantly improved. So the mental goal of minimizing total amount of medication is what's important. What you do? Any questions about pain? Again, this is not the time to answer every question, but this is the time for you to start really questioning yourself and look at your practice.
We put in the home med, we rush to get them in, we look at them, we talk them around, we make sure we use 12 different pharmacies that they go to, put them all together for the doctor to look at, but we don't always take into consideration that we're out here giving them any of those things. And maybe 2 or 3 days
Sure we
go
do.
by, and we try. It doesn't always work. I'm just saying if they're smokers for sure, they're drinkers, we do pay attention to that a little more. And they're on 3 Xanaxes every day, high dose or something, which is not always good about. We look at it and kind of think about it, but we don't. We need to think differently or more often. So kind of be better there.
Anything to minimize the total amount of medication. But if they're already on Versed, they're already on propofol, adding back those medications isn't always necessary. Same with their pain meds. But adding anything back that you can, but also remember a critical patient doesn't necessarily need all the things that they needed.
Right.
Plus, a lot of things that they needed on the outpatient side is many times more than they necessarily needed in the first place. So always worth considering, especially, there's not in the critical arena, but in the post-operative patient population, there's a significant series of studies talking about caffeine intake and making sure the patient receives some measure of caffeine during their post-operative period cuts down on pain medications, cuts down on headaches, cuts down on a lot of things. We forget that they're addicted to some of these things. We forget if they are on Percocet scheduled, maybe using that could minimize your total, those little things that they otherwise may be standard for their system as a way of getting off these medications as well. Any questions? So a big thing we're looking at trying to do is fix the pumps. If we can fix the pumps, I think that will answer a big part of the equation. The challenge for you though is how to remember to do it. How to remember mentally as you walk in that room, thinking about intervention, cutting down total amount of medication, working back that infusion. RAS score is 0 is #1 priority. And if they can't achieve it, why can't they achieve it? Is it because you haven't turned things down, or is it because there's another issue? Remember, a lot of these things really are diagnostic as much as they are therapeutic. That increased pain need may be there's a problem. Ischemic bowel, the necrotic foot that we didn't catch. Again, the fractured elbow. I don't think Brandy's on this, but the fractured elbow, which was fun. Anybody know that story? Is she on there? Hi, Brandy. She can tell you about it. No comments. So moving on.
Don't forget Keith.
Well, of course. Moving on.
Thank you.
B. So B was breathing at one point, obviously, but B stands for both, which is the spontaneous awake trial and spontaneous breathing trial. Respiratory will tell you, when I first got here, there's a little bit of a challenge between mechanics at 4 in the freaking morning and just doing spontaneous breathing trials. The guidelines have been pretty clear for a while in terms of the coordinated effort of awakeness and breathing trials is really the key feature. But this is also again back to A. And when we get to C, the medications we're using. I don't know how many times I'd hear them try to do a trial and then no, patient's just too sedate. And we're talking 8 o'clock, 9 o'clock in the morning. Right? That shouldn't be. It just shouldn't be. That doesn't mean we necessarily need to do it early in the morning. Doesn't mean we necessarily need to do it later in the afternoon. But the coordinated effort is the key part. Standardized approaches doesn't mean there aren't going to be exceptions, but standardized consistency is what gets these people off the vent fastest. So that we are cutting back the sedation earlier. And that doesn't mean I'm not a big believer in turning everything off. I think that's inhumane in some cases when you go from 0 to 60 in 2.2 seconds. That can be dangerous in some situations too. But in truth, if we have titrated these things back to their least amount of medication, you shouldn't have to turn anything off. If you do, they're over-sedated. Walked into a patient, was told that they were a -2 through the night. On my exam, they were more like a -4. Both are wrong. The goal was 0. So if they were -2 through the night, they're on too much medication. Back to goals, back to assessment, back to documentation, back to titration to that assessment. That allows this to happen. That allows they're already awake. They're already interactive. I know I'll get texts occasionally. Hey, this person looks great. They're giving me a thumbs up. It's 6 in the morning or 7 in the morning. Great, pull them. Let's trial them. See how they do. If they do great, pull them. It's not always the case, but for those rare situations that they are otherwise looking good and interactive, yeah, we want to move forward quickly and get them off the vent as quickly as possible. But routinely, one of my goals from a consistency standpoint, I think my partners are in agreement, is making 9 o'clock being the target. Why is that? Because then you get your shift change done, you get your assessment done. Sometimes you can get some of your meds done. And hopefully, if they haven't been titrated back down for some reason, because of busy or whatever, you can finish off whatever titration, trial them by 9 o'clock, see how they do on rounds, extubate by 11, reintubate by 1. Well, at least it's done. At least it's done in the light of day. So, is 9 o'clock the best time in the world? Not at all. Is it better than any other time? There is no better. The better is consistency. My long-term goal will be is once we've achieved consistency, it won't freaking matter. If they look great at 4, they come off at 4. They look great at 10, they come off at 10. Whenever they look good, we move forward. That there's a communication. The biggest part to this, that was a little blurry. The biggest part of this is the communication between nurse and respiratory. That's it. So if you guys could come in at 6, if it's night shift that says, hey, it's 6, patient looks great, how about we just trial them right now? Rock and roll. And there's consistency with practice, pull them by 6:37. I don't care. But now we're consistent in how we're approaching it. Until that is achieved, there has to be other things. What you don't want to do is do too much at shift change, because everything falls apart at shift change. You want to make sure you're not doing full-on assessment while they're trialing, because that can be its own impediment on its own from that perspective. We want to make sure people are more available. I know RT is more dedicated to the unit than they were in the past, which helps a ton. Our consistency from a sedation standpoint is really the other part to it. And then communicate with one another, hey, they look great. Why don't we go ahead and trial them right now? And then you go. These are the 2 primary things. Obviously, no active seizures, alcohol withdrawal, agitation, and paralytics. Duh. Myocardial ischemia. Yeah. And then obviously reasons for failure. And then again, back to consistency for it. Beyond this part on the right side is really the communication. Because if you guys can time it appropriately, if you can time it where I'd never hear RT ever say they were just too sedated. It will all take care of itself. My still long-term encouragement, at least until we get that communication without problem, is whether it be an 8 or 9 o'clock period, allows day shift to come on, get your assessments done, and move forward from there. Some people had questions about pain, about getting medications in. I really don't care. Whatever works, it has to be consistent. It has to be day to day, week to week, regardless of who's here, regardless of who's on. Okay? You can have the highest performing nurse, the highest performing RT. You can pull them at freaking 3 in the morning. I don't care. One of those is not one of the higher performers, mistake's going to be made. And that's where we need to narrow the spectrum. The other part to this, though, also, I believe, applies to, honestly, non-vented patients as well. While liberation is applied primarily to the vented population because the medication is used, there's no reason this doesn't apply to a BiPAP patient. There's no reason it doesn't apply to an Airvo patient. It doesn't apply to any ICU patient. While their breathing may not be vent and spontaneous awake, it still may be, what is their breathing pattern? What is their oxygen level? What is their CO2 if it hasn't been checked? Are they doing well from a respiratory standpoint? No different than pain. If respiratory issues are still there, we're not going to move forward. That's going to create its own levels of delirium, anxiety, stress, whatever. Okay. One of the reasons why, again, regimentation is key. Moving on. So choice of analgesia and sedation. This goes back to side effects of medications. The men's trial, which I didn't get to put into this, I was hoping to. I didn't add as much as I wanted. Compared dexmedetomidine with Versed. Dexmedetomidine won hands down in terms of throughput, time off the vent, all those things. More recent study, probably within the past 2 months, compared propofol and dex. They're equivocal. Why would that be? They're both short-acting agents. And while benzodiazepines are GABA-mediated, and propofol is GABA-mediated and typically tends towards delirium, because I think you could titrate those down more exquisitely, the patient gets off the vent faster. That's really the most important thing. And then subsequently coming off the medication. The upside to Precedex is you don't have to turn it off. And I do think there are added long-term benefits to its use beyond just the ventilation stuff, in terms of delirium, in terms of management within the ICU and sleep patterns, all those things. Okay. Fentanyl, why do we use fentanyl predominantly? Fast on, fast off, why else? Why else do we use fentanyl?
I mean, I'm not a nurse, but you're also.
You can use it. You can use any narcotic sedate. Why fentanyl specifically? And you guys on the computer, you're lucky I can't see your faces, otherwise I'd pick on one of you. I already made fun of Brandy, so I'll leave her alone. It's the most hemodynamically stable. It causes the least amount of histamine release. That's why anesthesia uses it so much, as opposed to morphine and hydromorphone. However, it has a byproduct, a metabolite. Hydromorphone does not in most cases. There is some neuroexcitatory side effects of hydromorphone, but both morphine and fentanyl can have an active metabolite that can cause further problems. I know we've seen some benefits from switching from fentanyl to hydromorphone. It's a little bit longer acting. Pain control sometimes a little bit better, not always, but sometimes a little bit better. Fentanyl seems to be, you can get serotonin syndrome also with fentanyl, but it also can be kind of on and off. There's very little in between pain control wise. I think you've probably seen it where, you give them a shot, they're doing great, then all of a sudden, boom, they're in pain again. Whereas hydromorphone, as it comes out of their system, they start recognizing they're starting to have a little bit of pain. It doesn't just sort of all of a sudden manifest itself. Why is this important to distinguish? Like Penny was mentioning earlier, if you notice it's not working, it may not be working. It's not that pain control was the wrong way to go. It's just what you chose of them. It doesn't work. I've seen people where fentanyl doesn't touch them, and hydromorphone does. I've seen where hydromorphone doesn't touch them, but fentanyl does. There may be other things like T was referring to. Maybe you need, why are we not on IV Tylenol at this point? Why are we not trying ketamine? We're still working on that, by the way. Eventually, hopefully, we'll have that as a pain control agent that we can use more routinely than what we do currently. That would be a way to minimize narcotics, allowing the patient to be a little more alert, while also having the analgesic and mild sedative effects as well. At the end of the day, it doesn't matter if your assessment's not there. If you're not recognizing trends or recognizing when something didn't work. That's the biggest, most important thing I think that you need to be able to do. When you do check your CPAP or VES and it's not being controlled, why? Why didn't it work? Whether it's the tube, whether it's a fracture, whether it's they're constipated, abdominal compartment syndrome, ischemic bowel, they got an ulcer on their heel we didn't see. Is there a reason why it didn't work? If there isn't, then maybe it's just the medication. We need to change it. You can also develop something called tachyphylaxis, where the pain medication just doesn't work because you've been on it for too long. Same thing goes, they need sedation. Propofol is really good for about the first 5 days, I think it is. After that, the buildup in the system, it doesn't come out very easily. very lipophilic. It's why it's what it is. It can take a while to clear system once you've been on it for quite a while. So choice of medications, adding adjuncts, getting back on home medications, whatever it may be. Yeah, that's the stuff that we need feedback on constantly. And if we have the mentality, the philosophy to be on the least medication possible, that's the thing that's going to drive how you look at this person a little bit differently. Delirium. So one of the things about the AEF bundle that I think is important, when I went to the conference, I think it was a year ago, I can honestly say I didn't really understand some of what our goals were. Yeah, getting them out of the unit was fine, but when you look at the bundle itself, while it is A through F, is there a hierarchy? Is there a goal for each thing? How do they interact? And when you look at it, the A, B, and C are really the priority. Because if you fix those and do those correctly, D doesn't happen. You don't treat delirium, you prevent it or you minimize it. There is nothing that treats it. Even Precedex, as good as it is, doesn't treat it. The more awake that person is, the more interactive that patient is the best that they do. What is delirium? Delirium is waxing and waning of a person's perception of what they're facing. The more alert and aware they are and able to understand what they're facing, the better off they do. Anyone been to the dentist? Yeah. I get in my little happy place to stare at the ceiling and try to stick on one little dot and then start counting them. But I can withstand some discomfort a lot easier when I'm aware of why I'm doing it or why I'm going through what I'm going through. Patients are the same way. Not that I want them to be in pain, but the more they can be alert, interactive, engaged in what they're facing, the better off they do. Delirium is an indication that they have not been engaged. Sleep deprivation, pain medications, underlying illness, underlying chronic illness. There's so many, no windows. There's so many things that obviously contribute to their awareness. When I first started working here, I completely lost track of freaking time. I'd come in and next thing I know, it's 2 o'clock in the afternoon because even with the windows in the rooms, you still didn't get a lot of ambient light to the point where you knew what time of day it was. Even with the skylights, it didn't always do that for you. In certain times of the year, it was 5 o'clock before you knew it. So imagine what that patient goes through. Now they're sedate, and then we're doing things to them that they can't control. We're doing things to them that cause discomfort, that disrupt their sleep, that don't allow them to ever understand what they're facing. And then you wonder why they have nightmares, why they have PTSD, why they have all the things that post-ICU syndrome otherwise causes. So A, B, and C are really, if a hierarchical need, the way I look at it, are really top. If you get those 3 under control, truly adjust your meds, truly monitor your pain, truly keep that person engaged, then D honestly goes away. And then E is allowed to happen. Your primary goal is E, and we won't get into management of delirium. I encourage you to look some more stuff up. Some of the things we are doing, though, people that have been on when I've been working, I've been using Depakote pretty functionally. It's been shown in a couple cases to minimize total amount of antipsychotics. No antipsychotic fixes delirium. It slows them down, sure, but it doesn't fix anything. There's no mortality benefit. There's actually, in some cases, mortality increase. What it does is buy you time to use less sedatives and hopefully allow that person to be more alert. Doesn't. No outcome benefit. Why do we use them? Really, it's like using methotrexate and rheumatoid arthritis. You're steroid sparing. In this case, you're sedation sparing. Precedex probably has the best track record in terms of a sedative as well as a delirious management. You can look at post-operative patients using Precedex cuts down on total amount of delirium. I don't think it treats it. I think it allows them to sleep more appropriately. It also has analgesic properties, and it doesn't affect chemicals of their brain in such a way that it affects how they alert or how they are aware of things. Precedex's biggest problem in the past was people were all kinds of freaked out because the patient heard and remembered everything. That's something else to keep in mind. For those that have been around a while, the benzos offered some retrograde amnesia. Well, I didn't say that. What? Yeah. Precedex doesn't do that. So while you think they might be out, they're hearing everything. That's both a good thing and a bad thing. Just be wary of that. Keep that in mind. Moving on to exercise mobility. This to me is your final target. This is what our goal is. So if the first three treat or eliminate D, the first four either make or break E's possibilities. And I don't have any of the OTs and PTs here today. I don't know if anyone's on the line, but this is really your goal. So what does this mean? Philosophically, your question every day should be, why are they not up? That should be the question. Why are they not up? And if it's any one of the four, fix it. They got to be up. There should be no reason, very little, very, very few reasons why they aren't up in some fashion. Now, what does up mean? Another thing that we found will be a big obstacle or things that we're going to try to fix is the types of beds that we have. So there's a bed called a Craig bed, I think, that has a foot plate on the end. You can literally get that person standing upright with a push of a button, and it was the entire bed up, and the patient can stand on that plate. Well, that's going to be the final solution or not, I don't know, but it's a grand idea, especially when we're short on staff or we're busy or whatever. One person, you keep the person strapped in. It's like the Barney chair, but they don't have to get out of bed. You can still put them on their feet. Why is early mobility beneficial? What is the purpose of it?
Atrophy and breathe better.
What I hear is
Decreases comorbidities.
Muscle atrophy.
muscle atrophy.
Deconditioning, she said.
We're gonna say, Claudia.
I think the faster you can get back to breathe, whatever you were, the faster you can get back to from the word activities of daily living, the faster you can resume that.
Sure.
The better your outcome will be. So, hey, if you can get upright, as soon as you get upright, better off going to be.
But fluid shifts when you're laying flat all the time. helps
Pressure
breathing.
sores, fluid shifts, atrophy. Someone said something online.
I said it decreases comorbidities like pneumonias and stuff like that.
Well, it decreases time on the vent. That's the biggest. But why? The real question is why. I mean, I think we talk in generalities, but the reality is anytime that you put pressure through your feet, anytime you make a person's muscles engage, they're stimulating the muscle with their own nerves. You have a person that's laid in bed for 10 days and you have done nothing with them. It will be impossible for them to sit upright without maximum effort. So if they're using maximum effort, what are they going to do? They're going to breathe faster. How are you going to get them off a vent if it takes just effort to sit up? Daily living, all those things down the road, 100% agree. But in the short term, what you're maintaining is muscle tone. So that when they do try to get up, you're not increasing what's called oxygen demand for that brief time. Also, upright drops the diaphragm, lets them aerate lower lobes better. Why does proning work? Same reason. You're allowing the posterior lobes of the lung to be engaged. When a person's upright, you do the same. That's why spontaneously breathing on a ventilator is imperative. We don't really get into that in this discussion, but honestly, that's another reason to not be so sedate. The more they can breathe on their own, they can generate their own diaphragmatic contraction. The more the diaphragm stays non-atrophied, and the better they do the next time you actually try a spontaneous breathing trial. When they fail those SBTs, why do they fail? They were too sedate. They've been on assist control for 5 days straight without it breathing spontaneously. There's no way they're going to do well, not significantly. Reason why I want to make the distinction is, in the past, bag and drag was kind of the fun thing. Well, let's get them up and make them walk in the hall. That looks cool. Yeah, that's how you rip out a central line, pull out the ET tube, and you put a hole in the wall with the IV pole. The reality is all they need to do is be upright. And if you can get them to walk around the bed within the confines of the circuit or within the confines of their tubing, that can be just as effective. If you can get them to sit to stand, that can be just as effective. It doesn't always require a PT to do their intricate work to get that person upright. That's something you can do.
Is sitting them in the chair position beneficial? I mean, a little bit.
I think at the end of the day, they got to put some kind of weight through their feet. That's why I think if we can get to a bed that can get them upright, even if safely, transiently, even if I mean, they're strapped in, but they can put some force through their body. When you go to stand up, you have to engage all those muscles to keep yourself from crumpling. So even if you are strapped in, obviously you're not going to put a neuromuscular block person in the same way. You might, well, the face is just like laying there.
You can technically, if anybody can find the dang shoulder straps to our from the chair.
Why are their hands white? Well, they're kind of laying on the strap. But the idea of putting that population upright is to drop the diaphragm, let the aeration change position, fluids, wounds, all that. The person that can otherwise engage their muscles, you put weight through their feet, all their muscles will engage. They have to. It's just the natural way our body reacts. The more they're awake, they can do that too. The beauty of a bed, if we can make those happen, which I'm hoping will happen, is then it doesn't require 5 people in the room. It can be one person. Hey, we're really busy today. It doesn't matter. I can get them upright. We're good. Get them back. May not be as ideal, but at least we're doing something, and it keeps them mobile. I've been talking with therapy extensively, probably since hell before I even started here, trying to come up with some protocols to make it functional for everybody. They have limited staff like everybody else. They do, or they do in transition. Sometimes just policy. So philosophically, if that's the goal, what's that going to make you do? The minute you see that order, you're asking why it's been suspended. If you're seeing it's still suspended, why? I've got to have a reason. We have to have a constant reason. It has to be a definitive reason. And if there is no good reason, then unsuspend it. The pressure from you, the pressure from me, the pressure from RT, the pressure from PT, all of us should be asking those questions constantly, every single day. Because if we don't, they don't go.
So are we okay to unsuspend that order? Because a lot of times it's because of.
Yes. I say yes. I say ask a question. I mean, just fine. It just, all we got to do is ask the question. But you can see where if our philosophy is about why are they not up, it changes how you're going to look at that person. Just that simple change in perspective, how you look at this individual, is going to make you do things a little bit differently. It's going to make you, well, yeah, their medications are too high. Let's work that back. I don't need them necessarily to be unsedated. If they have to be, they have to be. But there's a reason you can justify it. They're not just sedate through the course of the night because we just felt like it. They're not, at a higher level because I just got bored and that's why I figured I'd, let myself eat lunch. There's a reason behind the things that we choose to do, but with a constant pressure to decrease everything. Okay? And then finally, if you fix A through E, then F is happy. Right? You can see if that patient's up and moving, interactive, engaged, that family's going to be happy. They're going to be more excited, more hopeful, more encouraged. There is post-ICU syndrome. PICS. If you're not an acronym in medicine, you're nothing. So they finally came up with a special one. There's also FPICS. So whatever you think that you do to the patient, you're doing to the families too. When they can't interact with their loved one, when the patient's family is stressed about X, Y, or Z, you're causing just as much PTSD in them as you are causing on the patient. And I say you because, yeah, it's you. You're at bedside. You're in control of a lot of that. That doesn't mean we as providers don't have our responsibility to play. But at the end of the day, those of you at bedside that are activating and doing things, unfortunately, you're going to be at a higher responsibility. And you're going to have to be challenging us, pushing us to justify why we're doing what we're doing. On the flip side, you need to be telling us when something doesn't work or when something does work, when we can pull them early in the morning, when, hey, no, we need to try X, Y, or Z and do something different. That constant communication. That's what's imperative. So that brings up, crap, it's working now. So whatever. If it works, it works. So at the end of the day, what does that mean for liberation? One of the things is if I've looked at this and when I went to this conference, originally I kept thinking about vents. And then as they started talking about liberating from my iatrogenic injury, it became apparent how powerful this actually is. But what else does it do for us? For who? Who does it give a system to?
Everybody.
Everybody. Why is that important? Well, one of the other things that I heard over the 2 years I've been here is the various little, dare I say, bitch sessions of each little group. And that's recorded. Yes, I said bitch sessions. Shannon said balls in the wall earlier, so we'll leave with that.
That was recorded, though.
But day shift to night shift to day shift, RT to nurse, nurse to PT, PT to RT. Everyone complained about everyone. All the time, 24/7. Shoot me. Of course. Of course we do. But the reality is you guys do 99.9% of the work. So when you don't communicate with one another, none of this happens. None of it, regardless of what we do. I can put the best order set in place, doesn't happen. I can put the worst order set in place and they can still happen in a positive way because you guys are communicating. The other thing I liked about Liberation is it causes a constant, consistent line of communication across all parties. So the RT can pick up on delirium. The PT can pick up on respiratory failure. The nurse can pick up on the patient's readiness to get up and move. And the more you all communicate with one another, the better this all goes. And regardless of your disparity, whatever questions you have about one another, it doesn't matter. Now the communication is consistent. Best example is a code. Everyone can complain about everybody, but the minute a code happens, all that goes out the window. Because there's a goal to achieve. The same's here. And while obviously not as severe as a person who's in arrest, just as powerful, if not more so. We have a lot of fun crap that we do. We do Starling, we do ECMO, we do all stuff. But honestly, just the basics of management, which this is, has a far greater impact than any of these other things that we do across the board and beyond the ICU, significantly beyond the ICU. We're talking 3, 6, even a year out. We do this right, you just change someone's outlook, chance to go home, chance to go back to work, chance to do all these things simply by doing what we already do, but doing it with greater consistency, greater communication, greater collaboration. And honestly, that's what we're here for. I know we don't get to see it very often, but I can tell you, the people that we have seen, think about it. Think how good you feel about that. Think how good they feel when they can get back to what they were doing. So if nothing else, my encouragement to you as you look through these criteria yourself, read about yourself. I don't need to sell you on it. This is what we're going to do. I can guarantee you that. It will happen. But I also believe this is the greatest way for us to learn to be more interactive as a unit, more interactive just in general at how we manage our patients, and have a greater consistency of communication. Now, my plan, as I told the group that I originally tasked us with, is really get it up and going within about 8 months to a year, because there's still some obstacles I got to get through. I got to fix, whether it be the pumps, the beds, certain other things. So if to this group, I'll offer, and the ones online, if there are other obstacles that you can think of that will make a big impact, let me know. As we look for equipment, or we look for monitoring, or we look for medications, whatever, some of those things you can't fix, only I can by going to whatever stupid committee I gotta go to. But some of it's just honestly communication with yourselves. So, my 9 o'clock in the morning rule, not law. It is a standard I want to see started. 8 a.m., I don't care. Pick a time, stick to it. And then from there, we expand. And as people get better, we get better in that respect. For say RT, understand what a RAS score is if you don't already. Talk to your cohorts, encourage you to understand what a RAS score is, have nursing educate you. CAM ICU scores, I don't see them ever in the computer. They need done. I haven't seen them documented. COP scores, or CPOT scores, they're not there. VAS scores, we need improved documentation. We're going to start monitoring this eventually, tracking it. We got to see our outcomes. We should see a betterment of total amount of narcotic use. We should see a betterment of total amount of everything, total decrease, length of stay, everything. So once we get up and rolling, be prepared to help with that, if you would.
We have tracked some of the data just since actually Rickelman has came here, and what we've been doing with early mobility and decreased ventilator days. We've tracked just the decrease in ventilator days. We definitely have had a downward slide. It's not a great, big, but there is definitely, yes. We did, we did this prior to COVID, and we've talked about what we're gonna do with our COVID population, if we exclude them or not as we kind of go forward. But up until COVID, and though, we haven't included those patients yet, our ventilator days definitely did decrease. So we're doing something right. Wasn't a lot, so we have a lot of work to do, but
Well, it shows you how this simple implementation can make a big impact. So imagine now if we could do the pumps at bedside. Imagine now if we have beds. Imagine, there's a litany. Lights on during the day. Any of those things, routines. I encourage you to read your own journals. There's just a ton of stuff. I like to see better music in the rooms. Music therapy is well documented to be beneficial. Earplugs for the patients, well documented to be beneficial. Cycling the lights, well documented to be beneficial. Some kind of routine that allows this patient to have consistency, that's what's going to give them the best chance possible. And then, of course, your guys' communication with one another is huge. I hear frequently, when I'm here 1 week, it's one way. When I'm not here, it's a different way. I want that to go away also. I shouldn't drive having lights on. I've heard when Rickelman's not here, lights don't have to be on. I've heard that before. Well, that means the person cares more about themselves than they do about the patient. There's a phrase out there that says there aren't bad teams, they're just bad leaders. That doesn't mean that the leader didn't do their job. It means they didn't get rid of the team member who wasn't part of the team. This is coming. That's not a threat, that's a request. This is a great way to take care of your patient, huge impact, better than anything else we probably have to offer outside of early resuscitation for sepsis. Long-term outlooks, learn this stuff yourself, drive us as providers to do better. There's newer things out there all the time. So as you leave this conversation, please educate yourselves. I can send you a crap ton of stuff if you want it, but it's on there online, it's free on SCCM. I encourage you to look at it. If you need help finding resources, let me know. There'll be more coming. The last thing I'll leave you with then is one of the things I know I was talking with Brandy and Keith about was any way to help you at bedside remember. I know it sounds funny, but as we're changing culture, we're changing practice, we get busy, duh. How are you going to remember? How are you going to change your thought process over time? That takes repetition, that takes exposure, that takes constant reminder, either from each other or from our environment. The rooms are terribly, terribly, terribly sterile. Obviously with the windows, it makes it even 10,000 times worse. So trying to figure out a way to make the room more engaging, both for the patient, the patient's families, and for us. So when we step in the room and we're wondering, oh crap, I forgot to do the PRN, or I forgot to turn this down, or I forgot to, how can we help people both, they've been doing the job for a while, and for the brand newbies that have never seen this stuff ever. So if you have any ideas, let me know. If I can fix the pump thing, for instance, how are you going to remember to do that? We've never done that before. That's a real change in everyone's practice. But to remember to do it is going to be the key. How do we have one of the things I want is honestly something like this. When you walk in the room, it's on the back wall. I love the colors. It's something that's bright. It reminds people it's there. It's part of the conversation. Families could ask about it, say, this is what we're doing. We need your help to help us with your loved one. Now that we have families more in there, how do we engage them? How do we engage the room? How do we make it better for all of us?
I would think, like I said,
Trevor, I want it bigger.
our rooms are not that big as it is.
Back wall, no, the back wall is. You can put that whole thing on the back wall.
They don't have to take down.
Those are on the side walls. We can
Just put it over the window.
we'll just put them, yeah, exactly.
Behind the column.
Then the column is the.
There-
It's too big, it's not gonna be movable and as usual. So like, it's nice if you.
Whichever.
My vacation up and bring it around and discuss it.
Whichever,
Whatever.
whatever you need.
This is all.
I think that would be an easy fix. I mean, so they could easily have that done and melt it on the wall. And I don't know if you asked for that. We're going back and playing.
Okay,
Okay, I'm gonna go ahead.
thanks, guys.
I'm gonna stop recording, but then I will do the drawing.
So,